Kia ora. This is the second lung lecture. We're going to talk about interstitial lung disease mainly. So in the previous session, we talked about adult respiratory distress syndrome and its correlate to diffuse alveolar damage. That is part of the interstitial lung set of pathologies. It is the acute part of it that leads on to chronic fibrosis in the interstitium. What we're going to talk about today is the dust diseases, pneumoconiosis and asbestos-related disease, and also hypersensitivity pneumonitis. Okay, so here are some key ideas. We know that interstitial lung disease can be acute or chronic, and acute disease can result in chronic disease. And the chronic diseases are the dust diseases, the granulomatous diseases, sarcoid and hypersensitivity pneumonitis, idiopathic fibrosing diseases, and also smoking related diseases. So let's start on those. So an important idea is that pneumoconiosis is caused by inhalation of inorganic dusts. So this is in contrast to hypersensitivity pneumonitis, which is caused by inhalation of organic dusts. Pneumoconioses often occur in the workplace, and they occur because dust can cause fibrosis. Therefore, it's related to both the length of exposure and the individual patient characteristics in their inflammatory response to the dust. Historically, the most important dust disease was asbestosis, followed by coal workers' lung, but now industrial practices have changed, and so often the most important disease now is silicosis, and this has emerged recently with the stone bench cutting industry, where lots of silica is released and breathed in, and then other metals can cause fibrosis. So let's start with the classic asbestosis. So asbestosis is what's called fibrogenic, so it causes fibrosis in the lung. This is one of these long asbestos fibers here, surrounded by macrophages, and we know macrophages release cytokines and produce fibrosis. It also acts as a tumor initiator and promoter through the both direct irritation and the chronic inflammation. And we know what it looks like down the microscope. So often described as clear fibers, and then they get little blobs of iron on the end, making them easier to find down the microscope. So what is the suite of asbestos-related diseases? So that often the thing that we detect that tells us a person has been exposed to asbestos are pleural plaques on the diaphragm. So pleural plaques don't cause any disease in themselves, but they are a good marker that a person's been exposed to asbestos. It can irritate the pleura, causing pleural effusion, and of course mesothelioma. The most important disease is that it causes interstitial fibrosis. Remember those macrophages releasing the cytokines, and is a big risk factor for lung cancer. So here we go. Here's a lung cancer. Here's a mesothelioma encasing the lung. All right. So silicosis in stone fabrication workers. This has been brought up by both the CDC and the Australian WorkSafe people. Okay, so people cut stone benches and breathe in the silica dust. Yeah, engineered stone, that's where stone is stuck together and then cut to size, and so we need to go through the usual public health things to reduce this increasing disease. Let's have a think what happens with this silicosis. All right, this is the pathogenesis. The silica is inhaled. It interacts with the epithelial cells and the macrophages. Inflammation of the inflammasome. So what does the inflammasome mean? It means a whole lot of inflammatory factors like cytokines are released, which then causes fibrosis. This is an example of the inflammasome that might be activated. Things like the oxygen free radicals. We discovered those, remember, when we were talking about emphysema. A whole lot of interleukins, fibronectin, and fibrogenic cytokines. You don't have to remember these, just remember activation of the inflammasome, or if you get the word inflammasome, activation of cytokines. So what happens then? Well, we get a bunch of fibrosis, of course, because the fibrosis has been activated, and we get lymphocytes around the nodules, and we get a whole lot of diffuse fibrosis everywhere else. So you can imagine this leads to quite striking restrictive lung disease. And on the X-ray, it leads to a this kind of reticular nodular pattern with the nodules predominating. Okay, so what's the difference between coal workers pneumoconiosis and silicosis? So we know silicosis is due to silica. When people go down mines, they often get exposed to silica as well. So people with coal workers pneumoconiosis often have a mixture of both coal and silica. So what happens in the lung is we get these black nodules, which have a similar structure to those in silicosis and contain both coal and silica. And the lung looks strikingly black, and the outcome is the same, which is a nodular and also interstitial, you can see it around here, fibrosis. Let's move on to granulomatous diseases, of which there is sarcoidosis and hypersensitivity pneumonitis. You'll remember what a granuloma is, I'm sure. So they arise in a type 4 hypersensitivity reaction. The primary cell type is the epithelioid cell, the activated macrophage, which can either be round here as single cells, this is Eve, or join together and form this giant cell. So this whole thing is a granuloma composed of giant cells, epithelioid macrophages, and often lymphocytes mixed in around the edge. That is a granuloma. A granuloma does not have to be necrotic, but it is in some circumstances, such as in TB. All right, so what is sarcoidosis? It's a systemic disease. It affects the whole body, and it forms these granulomas, which are common in the lung, particularly in the lymph nodes of the chest, where the typical feature is a widened mediastinum. But they can be found in the heart, eyes, lung, liver, everywhere else. As typical for autoimmune diseases, it's more common in females than men. And as I said, everywhere in the body, these non-causing granulomas, but particularly the lung and the mediastinal nodes. It's due to immune overactivation of CD4 positive T cells that secrete cytokines that recruit the macrophages, but what activates them? We don't know. It's probably a combination of an environmental trigger and also a innate immune overreaction tendency. Here we go. This is the widened mediastinum with the increased nodes. And this is this fine reticular nodular pattern that we find with the fibrosis associated with sarcoids. The little nodules in the lung parenchyma is what we get. Here we go. It's particularly notable around the bronchi and the blood vessels, actually. You can see it traveling through here. So what do we see? We see these non-caseating granulomas. They look like little cannonballs, yep, around the lymphatics, blood vessels, and bronchi. And they're also in the lymph nodes. But their end outcome, again, is fibrosis. Like with all the interstitial lung disease, they have a similar end outcome, final outcome, fibrosis. So how does that differ to hypersensitivity pneumonitis? Well, hypersensitivity pneumonitis, also called extrinsic allergic alveolitis or hypersensitivity pneumonia, again, is a type 4 immune response with activation of macrophages, this time to a known inhaled antigen. And the inhaled antigen can be come from a whole lot of places. Bacterial spores, for example, fungi, such as in hay or in the poorly maintained spa, animal proteins, such as in pigeons or other birds, or bacterial products. So I'm thinking things that bacteria release, not just their spores. There's two ways that hypersensitivity pneumonitis can present. It can present acutely or chronically. So if a person has an acute reaction to a fungal spore, for example, they will have a lovely spa, and then 5 to 6 hours after exposure, they will get these symptoms of acute cough, shortness of breath, fever, and they get white cells. And then it goes away until they have another SPA, and then it comes back again. Okay, if there is prolonged exposure, like there's a budgie in the living room and the person is inhaling the budgie dander and they're chronically exposed, then they can get progressive fibrosis. And it's kind of silent until it gets quite advanced. So people often present with unknown shortness of breath to respiratory clinics and get investigated. Really great clinical history determining industrial exposure, so a high resolution spiral CT, and then that will give people a good idea of what might be causing the this disease. So the first treatment, of course, is going to be remove the thing that's causing it. Goodbye, SPA or budgie. Okay, so what does it look like? So don't tell the radiologist, but I think that all interstitial lung disease kind of looks a bit the same. So we get bilateral diffuse nodular infiltrates, and that's a bit like sarcoidosis or Kohlwerker's pneumoconiosis to my eyes. Okay, so here we go. We get little nodules, and this shadowy bit down here is the increased fibrosis, and it corresponds again down the microscope to these non-caseating granulomas surrounded by fibrosis and chronic inflammatory cells. Okay, what are other fibrosing diseases? These are diseases that I'm not going to specifically teach about, but you might hear. They aren't specifically in our curriculum. So there is a whole lot of things that that can arise and cause fibrosis. Poorly understood, progressive, difficult to intervene with. I'm just going to pause for a moment there. Okay, carrying right on. Organizing pneumonia. All right, so we've moved past the interstitial kind of chronic dust diseases, sarcoid, granulomatous diseases, and we're going to move on to organizing pneumonia. So what is organizing pneumonia? So organizing pneumonia is the chronic phase of the acute DAD. Okay, so people have DAD and then it organizes and becomes fibrotic. So we know that you get DAD after a variety of things like infection and shock, but particularly infection. And what we get here is we get plugs of organizing granulation tissue in the alveolar spaces. This is the difference. It's in the alveolar spaces that then gets incorporated into the wall. All right, so briefly, again, remember, because this is a hard thing to do, we have the interstitial lung diseases, which can be acute and chronic. They are, here we go, the pneumoconioses, granulomatous diseases, fibrosing diseases, which we didn't talk about, idiopathic ones. There are some smoking-related diseases, and also the result of acute, which is organizing pneumonia. And there we go. There it is now in that slide. Okay, carrying on. All these pathways lead to the end stage of honeycomb lung. So this is honeycomb lung, not like honeycomb bees, but honeycomb like what the Americans call the inside of branchies. So this is hokey pokey lung, okay? And it's the end stage of all the interstitial lung disease. And it's just massive fibrosis. So we now see big holes because the fibrosis is contracted and it's blocked some alveolar spaces and it's pulled some apart, okay? So there's big holes with thick walls and virtually no airway exchange, which is why people become so short of breath. I did want to talk a little bit about vaping-related diseases because it is in the news, okay? So we know that e-cigarettes emit lower levels of of poisons into the airways, but they do have risks, and they have about half the risk of smoking cigarettes. What do they do to the lungs? Okay, so they can cause inflammation in the lungs, and as we know, inflammation is bad. They sometimes contain heavy metal oncogenic agents, which would increase the risk of cancer. So the inflammation will lead to increased airway resistance and reactivity, in other words, increased chronic asthma and COPD. We know that it can damage the epithelium. They can have some carcinogenic effects, particularly they have that, which means that there can be some increased mucus production and an increased risk of cancer. Whoa. And we know that once they get down to the alveoli, we know that they can increase surfactant function, they can knock out that antitrypsin, and they can cause acute inflammation. So they're not entirely benign, they do cause inflammation in the lung. All right, here are some MCQs. Let's have a pause, just switch it off, and try and work out what's happening here. All right, have you got the answer? Okay, so we've got a 65-year-old man. The word shipyard suggests asbestos to me. So does fire retardant insulation. So he appears to have been exposed to asbestos. He now has shortness of breath. So he's probably got lung fibrosis, right? Oh, and he's got a CT scan of his chest, which shows a large mass encasing the left lung. So he's got mesothelioma as well. So this man has got asbestos exposure with fibrosis and a mesothelioma. So which of these is he going to have? So what is the first characteristic finding in mesothelioma? It is diaphragmatic pleural calcified plaques. Okay, so the words most likely are important because it is possible that he might have a pleural effusion or been exposed to TB in the past or something, but this will be there for sure, number C. All right, here we go, next one. Let's pause for a moment. See if you can answer it. Okay, here we go. So he's 64-year-old. He's a dairy farmer, which to me suggests extrinsic allergic alveolitis because he will have been exposed to fungal spores and he's had a 15-year history. He's got a mild fever and it shows a bilateral increase in linear markings, which is typical of interstitial lung disease. He's got a restrictive lung pattern and his lung biopsy shows lymphocytes and plasma cells with interstitial fibrosis and small granulomas. And we know there's only two main granulomatous diseases that we're learning about. One is sarcoid and the other one is extrinsic allergic alveolitis, also known as hypersensitivity pneumonitis. So this is what he's got. So what's the most likely cause? Well, it's probably the moldy hay, but how does that do that? If you go back to the slide that we had, let me try and find it again. Okay, so he's got a CD4 positive T helper cell reactive immune response to the inhaled fungal antigen. So what will he have? No, he will not have this. This is Goodpasture's disease. This is silicosis. And yes, he's going to have hypersensitivity to the spores of this fungus. And he doesn't have TB because that will give a completely different picture. Okay, let's think about lung infection. So previously you have learned about both bronchopneumonia and lobar pneumonia, and you have learned about the stages of pneumonia. Okay, so the stages of pneumonia, remember you get a damage to the endothelial cells and you get this fibrinous exudate with bacteria in. Then we have neutrophils migrate and the fibrin's now a network that's trapping the inflammatory cells and the bacteria, which is still growing. And then the neutrophils kill and chomp up all the bacteria, and normally that gets then removed. Type 2 pneumocytes act as macrophages, and the lung goes back to normal. So that is the typical microscopic progress of bacterial lung infection in either bronchopneumonia or lobar pneumonia. All right, then there's viral pneumonia. Okay, so what happens in viral pneumonia? In viral pneumonia, we get a different picture. We get a lymphocytic infiltrate in the interstitium. All right, so bacteria go in the alveoli, but the viruses, what they do is they infect the epithelium of the lining. Okay, they release a whole lot of cytokines, and suddenly there's a whole lot of lymphocytes here, widening the spaces between the alveoli and causing difficulty breathing. And this is exactly what happens in a typical COVID infection, where you get the virus infecting the cells in the alveoli, releasing cytokines, and then causing an interstitial infiltrate. Okay, sometimes it can go bad, and too many cytokines can be released in the cytokine storm, and unfortunately affect the other organs. This is acute admission to ICU. Okay. Similarly, we can get infections with RSV, which do the same thing, CMV, which does the same thing, measles, which does the same thing. So the most, I don't quite know what fungus is doing there just at the moment. Okay, all kinds of viral infections, like pneumonia, influenza in its acute phase does this. Now, so here we go. So this is some key concepts, right? So pneumonia is an infection of the air spaces. Pneumonitis is an infection of the lung tissue caused by viruses. So it's in the interstitium. All right, then fungal infections can occur. I think we've got fungal pneumonia. Fungal infections can occur, but mainly they occur in spaces. Okay, so mainly they occur inside the bronchi or inside cavities already present in the lung, like in abscess cavities. Invasive fungal infections are really uncommon. Right. Complications of bacterial pneumonia. So what happens when people get bacterial pneumonia and it doesn't go away? Well, we've talked about this organizing pneumonia, okay? So this happens after both bacterial and viral infections, where you get the plugs in the airway spaces, which then organize and undergo fibrosis. The other complication is you can get a pleuritis, and the pleuritis heals by fibrosis. So fibrosis of the lung interstitium and in the pleural space are both complications of bacterial pneumonia. Other more acute complications are empyema. We've got an empyema here, thick, sticky, loculated, filling up the pleural cavity, and that is usually followed by scarring. And of course, lung abscesses, which I've mentioned. So abscesses, for example, can become secondarily colonized by fungi, but they're primarily caused by destructive type infections like staph and Klebsiella, and not like the typical pneumonia, which is caused by strep pneumoniae. Okay, let's think about abscess pneumonia. So abscess pneumonia is a mixed bacterial infection, because what happens is after suppression of the cough reflex, oral secretions go down into the dependent parts of the lung, taking the mixed flora of the lung, of the mouth, into the lung. Okay, so you get a mixed infectious bacterial population, and they infect the dependent parts of the lung when lying down. Usually you get a bronchopneumonia pattern rather than a lobar pneumonia pattern. So what we're going to do is we're going to learn some more by thinking about a multi-choice question. So pause the video and try and answer the question. Right, so we have some clues here. He's 55, right? Alcohol, which means he can have poor arousability. advanced dental caries, which means he's got poor oral hygiene, and he appears to be having a chest infection. There is a fluid-filled cavity in the right upper lobe. What is the most likely diagnosis? So, okay, probably not adenocarcinoma. It doesn't usually present with foul sputum. Abscess, yes, okay. So he could have abscess because he's got a fluid-filled cavity. Bronchiectasis, well, possibly. We did learn about cystic bronchiectasis in the last lecture, but he's 55 and not the typical age for it, so that is less likely. Lung infarct, no, they're peripheral and wedge-shaped. Mycoplasma, no. This gives a viral type pneumonia, an interstitial pneumonia. So the answer would be abscess. And he probably got it from inhaling an infectious mess from his mouth, and then that formed an abscess. Okay, we're going to think a little bit more about viral pneumonia. So let's think about viral pneumonia, in particular influenza. So we've seen this picture just before where we have widening of the alveolar spaces, alveolar interstitium, and preservation of the spaces in viral pneumonia. All good. Most patients recover. That's great. So in viral pneumonia, there's two danger times. The first is initial infection and you get a cytokine storm. And the second is a secondary bacterial infection. And in older people who die of influenza, it's usually the secondary bacterial infection that gets them. So we're going to look at COVID again. Okay, so what does COVID look like? Okay, so in bad COVID infections, remember, this is going to be a DAD reaction. All right, actually the same in bad pneumonia, but you don't usually get bad pneumonia. It's going to be a DAD reaction. All right, so you have infection. It infects the cells lining the alveolar spaces, which become sick and shed. The gaps in their little blood vessels can allow fibrin in, and it can form these hyaline membranes. And also it lets blood cells in, so you get these wet, red, heavy lungs with the DAD. But the thing with COVID that's different to most other things is it's also prothrombotic, right? So you also get these microthrombi in the little blood vessels. So COVID-19 in an acute bad case will have all the features of ARDS, but also microthrombi. This is what it looks like down the microscope. Okay, so this is an alveolar space. This is the fibrin inside it. This is the swollen and becoming fibrotic interstitial space. And this is the little microthrombi. So this is the bad endpoint. This is a typical early picture where you have the pneumocytes infected by the SARS virus. And this is kind of this is what would be happening in you at home. This is what would be happening in the hospital where we have lots of damage to the alveoli. And this will be an ICU admission here. Okay. So I did mention fungal infections of the lung. So fungal infections of the lung happen in two cases. The first is in people who are immune suppressed. And the typical infection in immunosuppression is pneumocystis, which lives happily in the air spaces of the lung. It's everywhere. I'm probably breathing some in just now. So it causes pneumonia in immunocompromised people. And it looks like this. It looks like these tiny spherical fungal organisms that fill up the air spaces like this. So people have difficulty breathing. But of course, if the pneumocystis is cleared, then there is no permanent impairment. All good. And then there's fungal infections. So fungal infections of the lung are opportunistic as well. They occur in stationary mucus. So they can occur in old abscess spaces where they form a fungal ball in the stationary mucus. That's an aspergilloma. Or they can occur in stationary mucus, often in asthma, where they can cause an allergic reaction from inside the bronchi. Again, pretty easy to get rid of with oral antifungals. And then there's the most dangerous one, which is invasive, that invades blood vessels and can spread around the body. I've just been joined by Peter Bethwaite here. Hello, Peter. I'm just recording a lecture for the students, so I will just carry on until 10 o'clock, if that's all right.
Yeah, that's fine.
Great. Okay, so the other kind of pneumonia that you need to know about is lipoid pneumonia. So in lipoid pneumonia, it is due to blockage of an airway. So imagine you have a tumor that is blocking a bronchus, and all the secretions from the type 2 pneumocytes, type 1 pneumocytes build up behind the blockage. And these are surfactant producing, and they release surfactant, and it's got nowhere to go. So it just accumulates and forms these yellow patches in the lung. Now, these aren't very good at air exchange anyway, because the bronchus is broken. So it leads to this yellow consolidation. Here we have a picture of them. All these foamy macrophages, maybe they are type 2 cells. All these foamy macrophages are type 2 cells. Ignore what I said about type 1 cells. And are filled up with this lipid stuff. So you might hear it in lung reports, but it's not a true infection, and it's just secondary to blockage. Here is a useful list of keywords for all the conditions. Just spend a little time reading this. Perfect. And that brings us to the end of our lung lectures. And thank you, and I will stop recording. Okay.